Heather and Ben, welcome and thank you for joining us this morning. I'll just ask Commissioner to do an acknowledgement of country before we start, please.
Thank you. I'd like to acknowledge we are meeting on Kaurna country. Pay my respect to Kaurna elders, past and present, and those who are emerging. And I also want to acknowledge all our Aboriginal children and young people who we want to make a better future for. So thank you.
Thank you. Now we'll ask you to affirm your evidence before we start as well, please.
Start there. You just repeat after me. I solemnly affirm that the evidence I will give will be the truth, the whole truth, and nothing but the truth.
I solemnly affirm that the evidence I will give will be the truth, the whole truth, and nothing but the truth.
Thank you. And please state your full name, occupation, and workplace address.
Ben Thomas. I'm the manager of the Child Protection Policy Unit in the Department of Health and Wellbeing, and that's in the City Centre Building, 11 Hindmarsh Square in Adelaide.
Thank you. And Heather, if you could also please repeat after me. I solemnly affirm that the evidence I will give will be the truth, the whole truth, and nothing but the truth.
I solemnly affirm that the evidence I will give will be the truth, the whole truth, and nothing but the truth.
Thank you. And please state your full name, occupation, and workplace address.
Heather Ann Barron. I'm currently acting Chief Child Protection Officer for SA Health and work in the Child Protection and Policy Unit, Department for Health and Wellbeing, 11 Hindmarsh Square, Adelaide.
Thank you.
Thank you. Heather, if we can just start with you, would you please give us a rundown of what the structure of SA Health is in terms of the local health networks and your unit where you sit with that, please?
Sure. So SA Health is comprised of 10 local health networks. 6 of those are in country regions. Each have a governing board and are responsible for the governance over their local health service delivery, which allows decisions to be made closer to communities, closer to clinicians, etc. The LHN CEOs are responsible for the day-to-day management and operations of the LHN, and the CEO reports to and is appointed by the governing board. The Department for Health and Wellbeing complements and supports the LHNs through high-level system direction and performance management, as well as its government departmental role in supporting the Minister and the Chief Executive in exercising their responsibilities. And we also have SA Ambulance Service that sits within SA Health, and that reports through to the Department for Health and Wellbeing. I can list the LHNs if you want me to, but...
if you don't mind, please. Okay. Yes, please.
So there's 3 geographically based ones in the metro area, so Central Adelaide, Northern Adelaide and Southern Adelaide Local Health Network, and then there's the Women's and Children's Health Network. And in the regional areas, there's Barossa Hills Fleurieu Local Health Network, Erin Far North, Flinders and Upper North, Limestone Coast, Riverland Mallee Coorong, and the York and Northern Local Health Networks. So that structure it came into being with the previous government, changed from where there was one country service before. Now there are 6 LHNs. We also have Wellbeing SA, which is a state government agency working across primary and secondary prevention to lead system change and better support community health and wellbeing, and the Commission on Excellence and Innovation in Health. And they provide leadership and advice on clinical excellence and innovation with a focus on maximising health outcomes for patients, improving care, championing evidence-based practice and clinical innovation, and supporting collaboration.
Thank you. This inquiry is focused on the Aboriginal child and the Aboriginal Child Placement Principle in its application in the state of South Australia, in particular with the child protection sphere. And we've heard quite a lot of evidence being put to the inquiry about the experience of Aboriginal young women in particular, and their experience of having notifications made of unborn child concerns through the health network. And that's a particular interest to the inquiry in terms of it appearing from the numbers and the statistics that we've seen from the Better Start data that the number of young women, Aboriginal women, who are reported as unborn child concerns seems simply disproportionate in terms of the regularity of pregnant Aboriginal women having those reports being made through the health system. Can you tell us, please, how many Aboriginal business units or advisory units exist in the local health network?
Mm-hmm.
Please.
So at the department level, there is a Department for Aboriginal Health,
Mm-hmm.
and then each of the LHNs have a director or an executive director of Aboriginal Health and teams that support their functions. Some don't have service delivery as their component. Some just have oversight and a strategic direction and so on for the network, and others also have service delivery as part of their portfolio.
So I'm sorry, can I just interrupt you there? When you say service delivery, what is that service that they...
For example, there may be... So, for example, the Aboriginal Family Birthing Program in one LHN might sit under the Aboriginal Health Service, but in another it might sit within midwifery services. So there would be differences in the way that those services are delivered. And broader than this, just about children, I'm talking broadly about Aboriginal health services across health. So there are policies and guidelines at SA Health level that govern the development of Aboriginal health programs. So we have the Aboriginal Health Impact Statement policy. So that this sort of high level policy direction is set by the department, and then the LHNs are expected to develop guidelines, develop programs, etc., in line with those policies. So there's Aboriginal Health Impact Statement policy and the Program Development Guideline and the Health Impact Statement Guideline. So they're things that the LHNs are meant to work within. Mm-hmm. When there are new policies or updates and revisions of policies, there is communication sent to all staff about that, but to provide input, but there is also targeted contacting of various areas for their input and feedback about revisions and updates that need to be made. So an effort is made to contact the relevant people to have input to those policy directives and guidelines when they are up for review. Mm-hmm. So in terms of, so then your question about how many, as well as the department then would say that there would be 10 Aboriginal health units, because there would be one in each LHN, but they would all be structured differently. Right. That would be an LHN level detail that you would, if you want that, we would need to go to the LHNs around that.
Sure. Thank you. Can I ask you please then, because we would like some information about each one of those, and in particular how many Aboriginal staff members each of those Aboriginal units have.
Okay. So
get that.
Will you ask us those questions after this, or do you want us to keep a record of those questions as we go along?
We'll keep a record of that and we'll
Right.
let you know at the end.
Thank you.
With respect to the care for pregnant Aboriginal women and or high-risk infants, is there a policy model in terms of the care to be offered to pregnant Aboriginal women within the state?
There is no single model of care for high-risk infants.
Right.
And as far as I'm aware, there's no single model of care for the Aboriginal family birthing programs.
Right.
Certainly there is a recommendation by our team, and I remember now that I forgot to highlight that at the beginning, but the Child Protection Policy Unit where we're from has been in existence for about 2 years. Mm-hmm. So followed a review of the health child protection services, and a recommendation was made to have a child protection portfolio within health as recognition that was something that was required. Right. So yeah, we've been around for 2 years. The focus has been on developing a model of care for the child protection services in health. Mm-hmm. Plus we have responsibility for the child policy domain within health, and a range of other things that we do. So, sorry, that's just an aside because I forgot to mention that, but certainly through our work looking at the model of care for the child protection services in health, it's clear that there isn't a single model around high-risk infant management, and that is recommended as a next step. There are individual programs across the metro LHNs that have birthing hospitals, and there are high-risk infant pathways in the regional birthing hospitals that are level 3 and 4 hospitals, but there's no single approach at this stage. So I think it would be a valuable next step to have an agreed model of care across the state and pick out best practice from those models that currently exist, and the evaluations or learnings from those to develop an updated model rather than probably an entirely new model, but a best practice model.
And in the development of that, and so I'm going a bit offline here, would there be any consultation with Aboriginal communities or Aboriginal health
Absolutely,
workers?
yes.
Right.
There would absolutely be consultation with, and also with interagency partners as well, to develop that, and whether that would be DCP and DHS as well as Aboriginal services, and within the LHNs and external to the LHNs. So yeah, definitely.
Thank you.
Was that in reference to the model of care
That's in
for child protection services?
That's in well, it's really in reference to the high-risk infant pathway, the high-risk infant program. So at Narlan and Sarlan, their high-risk infant programs or pathways, probably is a better way of describing them, sits under the governance of their child protection services, but at Women's and Children's and in the country LHNs, they don't. So that's really just more who provides oversight of them. So it's really that they, the oversight, probably it isn't essential that it sits under the child protection services. It's a pathway that is really important, that SA Health has a pathway and has a more standardised best practice approach. How that's operationally governed is probably up for the LHNs to work out, but there does need to be an agreed model.
Thank you.
And that's the aim of the model of care for child protection services across the whole of the health system.
That's the aim for having a high-risk infant pathway. So that's been sort of uncovered in the work we've been doing in looking at a model of care for the child protection services, that there isn't a consistent model for high-risk infants, but we don't think it needs to sit within the child protection services as such. It needs to be in each LHN, but it doesn't need to be under the governance of the CPS.
And who determines what the definition of a high-risk infant is? Is that each individual?
That's a good
health
question. Yes, I guess it would be up to the determination by the clinician who's working with that woman. Looking holistically at a range of risk factors around their presentation. Right. I don't know if that's defined on paper, but high risk factors around domestic and family violence and drug and alcohol misuse, and a range of those kind of factors would be typically the things that would trigger a response to think about that infant in a high risk situation.
And that would then trigger an automatic referral to DCP?
A notification, you mean? And I know that's a question that comes later, isn't it? Not necessarily. I think there needs to be a holistic look at that at that situation. health workers are mandated notifiers and need to report concerns about suspicion of abuse and neglect to DCP. DCP make the determination ultimately whether that's an unborn child of concern.
Sure.
Certainly we recognise the need and are working towards strengthening the response that health makes, that it's not just report and we've done our job, but that there's report and support.
Right.
So that if a notification is made, that then what are the supports that health needs to wrap around that situation, because realistically it doesn't mean that there'll be that DCP or other agencies are going to do anything, to pick up that the risk for that woman. That what can health do? I think we've got a long way to go, but that's what that's an area that we can see there's a great need.
Right. So that would be more of a public health sort of response to risk than an incident-based response to risk that we've got at the moment. Would that be fair to say?
I don't think there's necessarily an incident that triggers a notification. I think it's the assessment of risk that would prompt someone to make a notification to DCP, because that's what the mandatory
Sure.
Reporting guidelines policy rather require SA Health staff to do.
In the staff making that assessment, is there a consideration by them of the supports that are already in place for a pregnant woman?
Yes, and I think it's well recognised that there's probably insufficient resources for high-risk women in the preventative and early intervention space. We know DHS provide a range of intensive family support services, but they can't meet the need. So it is difficult to refer people on to other services because there's just not a lot of services to provide that support. So that's a gap in our system, and I think health probably, in previous times where there was more of a preventative focus, may have had a bigger footprint in this space, and there's we're talking more about health prevention and early intervention. That's coming back, whether it's a cycle or of, we need to return to doing more preventative work. We have Wellbeing SA, that's a recognition of that. But we need to be, that's broadly across all of health. We recognise the need for early intervention services for all high-risk women, and Aboriginal women are overrepresented in that.
Thank you. Good. In relation to the Aboriginal maternal infant care program, where is that workforce situated?
So there is an Aboriginal family birthing program at Narlan and Women's and Children's Health Network, so in Metro.
Can I just stop you there? Narlan is the northern.
Yes, Narlan Northern, which in Women's and Children's, we shouldn't use acronyms.
Yeah.
Southern Adelaide Local Health Network is looking to how it can better support Aboriginal women across these care pathways. In regional areas, Flinders Upper North, Eyre and Far North, River Mallee, Coorong, Limestone Coast have Aboriginal family birthing programs. Or pathways, but the makeup of those in terms of which, how many staff, etc., all of that, again, will vary across LHNs, and particularly in regional areas where recruitment and retention of staff is more complicated. Capability and capacity will depend on that. But all of those programs, and they're called Aboriginal Family Birthing Programs, AMIC are the staff within them, the Aboriginal Maternal and Infant Care Workers. Obviously, all of those programs aim to improve the birth outcomes for Aboriginal women and their families and provide culturally appropriate and clinically excellent care for antenatal birthing and postnatal care. And when you asked me before about models of care, and while I've answered that we don't have a consistent model, there are a range of documents that guide perinatal care. There's the perinatal practice guidelines and so on. So there are a range of things that guide practice, but and there are each of those high-risk infant programs in the metro LHNs have documentation about how they operate. There's just no standardised approach.
Right. Thank you.
So can I just ask a question then? With those guidelines and with the clinicians basically doing the assessment of risk, do those guidelines direct the clinician to consult with the Aboriginal professionals like the AMIC workers?
I know that some of the perinatal practice guidelines have been developed for Aboriginal women in mind. I think I'd have to check whether there's reference to that referral pathway. But certainly, there are multiple options when a woman comes into antenatal care about how they wish to receive that care, and one of those is the Aboriginal Family Birthing Program, if they are Aboriginal or having an Aboriginal baby. So those options are presented. So, GP shared care, midwifery-led care, Aboriginal Family Birthing Program. So the various options of care are provided to the individual.
All right, then. So the clinician is a very broad term. So who is the clinician? Is it a midwife? Is it, a doctor that does the assessment of high risk? Which clinician? Which professional group?
It would be midwifery, and it would also be medical. Both would make that assessment. Again, the detail of that we would need to check with the LHNs about the pathway into antenatal care in the public hospital setting. And the medical, the clinical condition of the woman would also determine some of that.
Yeah.
So in terms of the Aboriginal maternal infant care program, what specifically, are you able to tell us what specific supports they are able to provide for Aboriginal parents and families and children that makes them anything different from the mainstream maternal care?
Well, I think the main difference would be that there are Aboriginal staff, so the Aboriginal maternal infant care staff within the service that provide support to the woman. So there's that cultural support. Right. So I think that would be the distinct difference.
So do each of them have Aboriginal staff involved in?
Yes, the AMIC workers are Aboriginal staff who've done particular training to achieve that qualification. Right. And they work alongside midwifery staff, and they do clinical and non-clinical tasks.
Right. So when you say they've done specific training, are they nurses? Or do they all require nursing qualifications?
No, not necessarily. No? I don't believe so. I think I'm not sure how the training is delivered, but no, I don't believe they have to be nursing staff.
Right, thank you.
They could be, but don't have to.
Sure. And then in terms of engagement with patients with the AMIC, is that are patients able to ask to be referred into that, or is that a referral through the hospital? How do they become engaged in that? Do they have a choice in that?
Yes, I believe that there is a choice about which pathway, and I said before the different types of care. I believe they can choose to opt in to that service. Yeah, I believe that's the approach across all of them, but again, we can check.
Sure.
We could check that.
Thank you. As I've said earlier, the inquiry has heard that the unborn child concern notifications have been identified as a fairly significant trigger point for Aboriginal families, Aboriginal women coming into contact with the department. Do you have any data about the sources of the unborn child notifications within SA Health?
In short, no compiled data.
Right.
Notifications to DCP could come from anywhere across health,
Sure.
whether that's in an antenatal clinic, could be an outpatient appointment, it could be anywhere across SA Health community, hospital, any notification could be made. So no is the short answer, other than to say it would be many and varied.
Okay. One of the triggers for notifications and pregnant Aboriginal women being brought to the attention of the department appears to be quite consistently that if they don't attend 3 antenatal appointments, that being a trigger. From what the inquiry has seen, there is no legal requirement for attendance by anybody at antenatal appointments, is there?
No, that's correct. There is no legal requirement to attend an antenatal appointment. I suppose non-attendance would be seen as a potential flag in any appointment. So we have failed to attend policies or guidelines for appointments within health because and that's linked to policies around neglect and fabricated and induced illness. That's the policy title. Because it is good healthcare, to follow up people and ensure that they are receiving the care that they need. So and then there's good evidence that attending antenatal appointments leads to better health outcomes for the mother and the infant in the end. But in and of itself, it is not a legal requirement. It would be an assessment made by the clinician about whether there are other risk factors associated with that presentation to raise concern about the health and wellbeing of that mother and infant, as to whether that would prompt a notification to DCP.
Is there any capacity at all for any outreach from the AMIC to a young woman to address? There may be a lot of reasons why she's fearful of coming to a hospital.
Yes.
Is there anything other than her requirement to attend those appointments that can address those concerns?
Yeah, look, I don't know where all those services are delivered. I would be surprised if there were no off-hospital site deliveries of those programs. I know other antenatal clinics are delivered in the community. We do have some that take place in CAFS centres or children's centres. So I would be surprised if there wasn't any AMIC service delivery or in a community-based setting. But I can't answer that for individual LHNs. And absolutely acknowledge that there would be multiple reasons why someone wouldn't attend an appointment. Transport, having other children to care for, a whole range of things that add complexity to people's lives that make attendance, not to mention the fear of attending a hospital, etc. So, yeah.
Thank you. We've spoken, you commented before about the lack of early intervention and prevention services. The forums have heard quite a lot, even from your South Australian health staff, that there is a significant lack of early intervention prevention services for Aboriginal women and their families, both pre and post birth. Would you agree with that?
Yes, and I think I touched on that before, that I think, there aren't sufficient support services in an early intervention space for families to access. DHS have their intensive family support services. But they don't have sufficient resources to see everybody that is needed. Health has some level of service in that area, but it's not very extensive.
Do you see that as a role that health could and should be playing?
I think there is scope for health to have a broader role across the spectrum of child safety, and I think certainly the unit that we are in, that is something that we see as an important piece of work, is to look at how is health placed across the spectrum with health, with the safety of children. So we have universal services that anybody can access, and we do have targeted services that tend to be down the tertiary end, and then there's quite a bit of a gap in between where there are targeted services are needed, but there aren't a lot of those to meet the need. So, CAF's Child and Family Health Service, for example, is a universal service. It also delivers some targeted services for families who have additional need, but and the Yarrow Place have a My Place program that's in collaboration with DHS, and they support young people who have either been under guardianship previously or are currently and are at risk of having a child removed or have had a child removed, and work with that woman to support and prevent future removals, etc., and to build up their capacity to parent or prevent further removals, etc. So there's pockets of things that we're involved in, but I think across the spectrum of health there is scope to be more involved in the safety of children. And I think if we look at, say, from the maltreatment study results that I'm sure you're aware of, the vast proportion of people who have experienced abuse as children, and then the mental health impacts that has in their adult life, that's got to be seen in our mental health system, which is under health. And I don't know how well do our adult services recognise this, from back here in childhood, and how well are we connecting all of this together to work down here to try to have an impact on our health system in the long term. So I think health is involved, but I think we need to have a greater understanding of the impact of trauma on health outcomes, life trajectory, and long-term health outcomes, and its impact on the health system.
Certainly, thank you. I'll ask you, I've got something I'll ask you about that in a moment. We'll come back to that. When young women attend to give birth at one of our hospitals, and they've been identified as a risk within the hospital setting or the antenatal program, I think you've probably just covered off on most of it, but what supports or wraparounds are offered to them in the hospital setting to provide them with an alternative to having their baby removed at birth? I guess what I'm asking is, does health see itself as dealing with the health as such, or is there any holistic attitude within the health system that maybe if we provided and brought in other services that we could address this as a rather holistic view, rather than we're here to deliver this baby, the baby's at high risk, we've identified, pass it on to DCP, and then it's DCP's problem?
I think that's the overarching purpose of those high risk infant pathways, is to provide support to those women. There's recognition that we probably need to provide therapeutic kind of intervention and earlier. So rather than just noting the risk and monitoring and surveilling the situation, that there actually needs to be support, but it needs to be delivered quite early on, not at 36 weeks or when it's probably getting a bit late in the pregnancy to really make a shift. So earlier intervention. And it needs to be therapeutic as well as case management in that sense.
And is that available in this state?
I know and I can't speak for all the LHNs, but I do know the Salen model has done some evaluation around that and has really looked at trying to provide earlier support for women, and have found that those with moderate level risk are more willing to engage in services than those at the very severe high risk end, and that they've had some positive outcomes with that group of women. And so where I was saying before about developing a statewide model for high risk infants, I think we need to pick out the best of each and the evaluations that have happened. I know Narlan is doing a project currently, a northern based can't remember what it's called, but as part of their high risk infant program, and they're evaluating that, and they've said that already with a particular cohort of women, they've had some really good outcomes. So I think there are things to be learnt from what is happening. The unit we work in, we're just working with DCP around this because we're aware that it isn't necessarily always best practice, the process of the removal from the birthing hospital. I think from a health point of view, we would probably prefer those removals not to happen in a birthing hospital. And if they do need to happen there, we want to ensure that, again, that there is best practice around that, ensuring that the parents are aware of what is going on, and that support is provided to those parents. And in the very early stages of that, we're reviewing the, I can't remember the name of the policy.
Collaborative case management of high-risk infants.
Thank you, collaborative management of high-risk infants. And we're also just commencing an audit of cases where infants have been removed at birth, to just start looking at what has happened in those individual cases, to pull that together to kind of look at, okay, where are the, anecdotally we know of what I've just described, but over the course of, say, 12 months of data, what can we pull out from that to make change? And in that bit,
Right.
that bit alone, that's not the whole high-risk infant pathway, but that was one area that was identified that we needed to sort of do something about. But that fits in the bigger picture, and each of the LHNs are doing quality improvement work in this space, and we're also just trying to map that at the moment.
Right.
I know the Aboriginal Health Division at the department is leading through the LHNs the continuity of care protocols for Aboriginal children, 0 to 4, I think it is. And so, as well as that and other research that's going on, we're trying to map all of the high-risk infant space to kind of then say, okay, well, these are the pieces of work that's happening. We will do this particular project around the removals, the Section 41s, and see what else needs to, develop out of that.
That is very interesting to hear, because we've heard from a number of people giving evidence at this inquiry that there is another additional layer of trauma laid over young women who are not even told their baby's about to be removed, and trauma has brought them to where they are, and then that's laid over it, and they're left in the hospital without a baby with no services to deal with their grief, no trauma counselling, nothing, and so it just heightens
Yeah.
the already particularly
and
high
I-
trauma response.
And I think that makes a lot of health staff feel very uncomfortable.
I'm sure it would. In terms of that, is there any counselling and support offered to your staff? Because I imagine that would be a very traumatic thing to be involved in.
So I guess through our employee assistance programs and things, there is access to counselling all the time. Sometimes particularly traumatic events, prompt a debrief locally in a health service, whether that's managed by social work or someone else within the team within those services, those hospitals, to manage that around particular events, and, critical incident debriefing. That's what I'm aware of.
Thank you. I think my question at number 7, whether Aboriginal women and their families who've been identified at risk within the hospital are then given a choice of a referral to support services that may be Aboriginal-led. Is there a connection in the health system with those sort of services that might be able to offer assistance that may not necessarily be health services, but
I think the initial point of contact in most of the elections would be the social work departments, who would then provide that initial support and then make referrals out. What services they access and where, and whether they're Aboriginal-led, probably varies across each LHN. So that would be an LHN detail question, I think.
Okay. Thank you.
Yeah.
One of the very strong issues that has been coming through in the inquiry from the public forums and from various forums within the community is that Aboriginal people feel that they are subjected to increased scrutiny within the health system as compared to non-Aboriginal people. And this may well be a question that we need to pose to each of the LHNs in terms of their practice on the ground, but a number of the SA health staff indicated that the first point of call was not to ask what somebody needed for support, but to put in the call to DCP to ask should they make a notification. And it's particularly noted in the Aboriginal community. The Aboriginal women felt that was particularly their experience, that just their presentation at a hospital was enough, particularly if they have in the past been in any way involved in the department. It seems to tick in the box. If you've been a child in care or removed from your own parents, that in itself is a risk factor. You're then not considered a safe parent for the baby that you're about to give birth to. Can you comment on that?
My comment would be that being Aboriginal in itself should not be the risk factor. It should be looking at the whole picture around that presentation.
That's not what we're hearing from the Aboriginal people.
Yeah.
That is a risk factor in itself is Aboriginality is considered within the hospital system.
We know Aboriginal people experience higher levels of disadvantage, etc. That lead to poorer health outcomes, etc. But without looking holistically at the context, it shouldn't on its own be a reason to make a notification, and an assessment of that woman and the strengths and supports around her should be considered. I think, perhaps in health, where health has a disease focus, we focus around the deficit. That's how we deliver our support. You come in with an injury, and that's how we're funded as well. Whether that creates a bit of a mindset, I don't know. I think this is a broader issue about systemic racism, probably, and judgments that are made by people about other individuals. So I think the assessment needs to be made holistically about what the strengths are against what the risks are. But obviously, from what you're saying, that's not the experience of people, of Aboriginal women. We have, frameworks and so on that support access to services and support those people who are experiencing complexity and have the most need, etc. But people shouldn't be discriminated against because they're Aboriginal.
And Heather, on that point, is there specific policy and training within the health system to address that sort of systemic racism, or those attitudes that lead to that overrepresentation of Aboriginal women in the...
Well, we have, within health, there's the Aboriginal Cultural Learning Framework, and that provides guidance for the LHNs about their own learning and development programs for staff. All staff are required to do some basic level of training in awareness of Aboriginal culture, etc., and history. What the specific requirements of every LHN staff member couldn't comment, but and there would be levels of training. There would be a base level for everybody, plus more in-depth training, and certainly acknowledging that. And I don't know the right term, because I've used cultural competence and people have said, well, you never be competent. It's a lifelong learning. So it's not a tick in the box thing like learning hand hygiene and, washing your hands, etc. It is something that we all need to take personal responsibility for in learning and understanding and growing our understanding across the life course, and not just a one-off thing. But at a policy level, yes, we have a policy and we have a framework around that guides what the learning and development should be. And I know that some services across the LHNs also, where they work with Aboriginal families, receive some cultural supervision as well. That's not a broad, that wouldn't be everywhere. I suppose services that are more aware of their need to understand Aboriginal culture recognise that they need to be supported to help grow their understanding and learn ways of supporting Aboriginal people. In the work that we've been doing in the unit around the model of care for child protection services, it was really clear that at the Health Child Protection Services there was scope to improve the way they worked with Aboriginal children and families, and we've engaged KWI and a project to develop tools and better approaches in how those services engage with Aboriginal families, children and families who engage with our child protection services. So that project's sort of just beginning, but that will involve some community consultation, but also looking at how can we build a workforce in the child protection services that is including Aboriginal staff. I know there was a question about that also.
Was that put out to tender or a direct approach?
Direct approach.
So why was KWI chosen?
Because of their work in the child protection area, or working with children and families, really. We engaged with Snake initially to have a conversation about where we might put out feelers and so on, as well as talking with our own Aboriginal Health Division, which is where the funding has come from.
Right.
And that's how we've ended up with KWI.
Right.
So 3 sources of advice about where to go to. Snake, The
SNAC
Aboriginal
and the Aboriginal Health Division.
Yep.
Too, I guess.
too.
Yeah.
Thank you. I'll cover it off on in the public forums with the SA health workers, they described a pervasive risk-averse attitude which contributes to notifications being made to the department. And they've also described a focus on the deficit, as you spoke of that being the focus for health, is that something's wrong, it needs to be fixed. Is there a way that the strength basis of families, Aboriginal families, and their differences in terms of parenting approaches and connection to their children could be prioritised and included in the health approach for Aboriginal families in South Australia? Is that something that the KWY project is likely to be looking at?
Certainly for the scope of their project, yes, that's not all of health, that's just for the child protection services in health. I think it's about education.
Mm-hmm.
I think, our interpretation of what we see in assessment of risk is based on our Western, understanding of health and our healthcare models.
Sure.
And so through education about Aboriginal culture and their connection to family and their land and language and all those things that provide them strength and resilience, I think as non-Aboriginal people we need to build our understanding of that so that we have a better frame of reference in how we assess risk and have a more of a strengths-based look at families when they present to us.
So where does that education fall? Is that in the training in universities? Is that within SA Health? Is that within the hospitals? And who would assess that, education works if you can see a change? Who then, is it just that people are asked to read this information and tick the box that they've read it? How do we assess that change has come in attitudes, in particular because as we're talking about attitudes here, through that education that's offered to people?
Well, firstly, I think education should be offered at every level, and the earlier the better. At a whole of community level, if we want to make change, it needs to happen at all levels, and certainly undergraduate level would be a great thing to happen rather than just once people graduate and get into health services, or if they've grown up with that level of understanding, that's surely got to be better than trying to retrofit understanding. But so there are, as we said before, the framework and protecting children is everyone's business. We've recently completed an update of that mandatory training that is required for staff. And that highlights the importance of recognising and responding to child safety concerns. And we're also looking at reviewing the next level training, level 2 and 3, around child safe environments, which we will be aiming to strengthen that understanding of culturally appropriate responses, better understanding of trauma, history for Aboriginal people and what that means in terms of their presentations and taking more of a strength-based approach. So there's some education that we are sort of directly involved in having an influence over in child safety. In terms of assessing its effectiveness, it's very, of individuals, that's a hard thing to answer. I think we can assess the effectiveness of the training in terms of meeting its requirements, or how it meets the framework or that kind of thing. How effectively did the training set out to deliver what it was meant to? But on an individual level, have we changed attitudes? And I don't know how I can answer how do we do that. I'm not sure. Hopefully over time you would see a shift in attitude. pre and post testing of individuals, looking to see the way a culture in a service might change over time. They're things that I guess you could set up evaluations about, but on the whole of health, at a whole of health level, that would be complicated to do. But probably at a targeted level, you could do that amongst groups of staff.
And how, with the education program that you're establishing, how is that going to be delivered?
It's delivered online.
Right.
This particular training.
Okay.
Yeah.
Right.
A lot of our mandatory training is done that way. I do know for some of the Aboriginal cultural training it is done face to face. And again, that probably varies across LHNs.
Right.
But some, provide a 3-hour training block around things to have a much more, interactive, immersive kind of experience as opposed to reading something on a screen.
Sure. Okay, thank you. What guidance and instruction is provided to the local health network staff about how to support high-risk families outside their role of mandatory notification? This may be something that the local health networks individually might need to answer as well. But again, it's about looking at how we scaffold families rather than just have the health network sitting in a vacuum and families being expected to find their own supports when they're identified within the health system as high risk or vulnerable families. Does the health system see itself holistically as part of that?
Yeah, through the high risk infant programs, they involve the other agencies in those meetings. And then
So what other agencies?
like DCP and DHS.
Right.
So they will attend those meetings to discuss individual cases and how to best manage those.
Are the AMIC professionals involved?
I don't know. I'm not sure about that. Yeah.
Something to ask.
Yeah. There's the child family safety network meetings that are across the geographical spread of the state, and health attends those. That's not just around high risk infants, but that would be around high risk families more broadly, and how as agencies we're helping to support those families. So that interaction between DHS, Health and DCP can happen at those forums. I think there's scope to improve those forums, as well as said before, having enough services to refer people to get the support they need, so we don't end up just talking and monitoring
Sure.
that there's doing.
So what do you see as the hindrance to enough services? Is it funding?
Well, funding is always a factor, but it's also having adequate workforce. We're facing workforce challenges across all areas of health, or across many industries. It's not just health, is it? And that's been talked about for a long time with our ageing population. We knew we would reach a point where we weren't going to have sufficient workforce to manage demand. So I think we're sort of we're approaching that. So just throwing more money at things isn't necessarily going to solve the problem, and we need to look at other creative ways. And some of the examples that have been, we talked about at a symposium yesterday, which have been around, but where other peer support, other lived experienced workers, people working alongside, families by family, helping to support. We need to look at other ways of providing support to families in communities, because official health services or DHS services can't deliver it all.
Thank you. I think we've answered the question about the infant removals within the hospital causing trauma for all parties. The difficulty is, one of the difficulties we've identified is that sometimes even the staff of SA Health are not informed of a Section 41 removal until the very last minute, and that leaves them very vulnerable as well. And they're then left to deal with an angry, distressed, grieving parent who had no notice of this. What would be your recommendation for how those urgent removals should be managed within a hospital setting?
So that's something that we're hoping to address through this project that I talked about earlier, where we review the policy and the practice across health and DCP and work together on that. DCP make the decision about the removal and enact that, and we're party to it. And yes, it doesn't necessarily follow the way that health feels comfortable with. I think that, there needs to be greater transparency with families and ensuring that they are aware and involved in those discussions that affect them intimately. So I think the fact that happens would be against the policy and practice guideline, and so we need to address that. Okay. Which is why this has been identified as a high priority project to look at, and we're starting to gather that information now.
And when those removals occur, that's completely out of the control of anybody in the health system. You don't get any input into that at all.
I think again it probably varies across LHNs in how that occurs. There are DCP staff who are placed in. They have been sort of like joint appointments. I think they're funded by DCP, but have been placed in the hospitals to work in the high-risk infant space. And
Wasn't aware of that.
So,
has that been a long-standing arrangement or a more recent initiative?
in the last 5 or so years, but I don't.
That's not really recent, is it? Yeah.
But I don't know whether they're still happening. But that was to try to bridge some of that, bridge that gap and have that. I don't think they were permanently, like full-time placed in the hospital, but they would be there routinely in the, would be in the birthing area, the midwifery area. So I know Women's and Children's did have a position at one stage. I think Narlan does, but I that would be a question for the LHNs, and I don't think that any of the regional LHNs would have that, but I'm not sure.
Sure. Okay. Thank you.
And I don't know whether any evaluation was done about that arrangement to see how effective it was in trying to facilitate that relationship and working around those Section 41s.
Sure. Thank you. For your staff in Child and Family Health Services, they're non-Aboriginal, antenatal carers, social workers, child protection, paediatric services. What cultural competency training are they provided, if any?
I think I probably covered that previously by saying that there is a requirement for all staff to do at least a baseline level of training around cultural awareness, and hopefully more than just that superficial level. And certainly people who work with Aboriginal families would be expected to do more training, and likewise working with children have greater levels of training that they need to undertake around child safety. So that's guided by that cultural learning framework, and those programs are developed. I don't know whether each LHN has their own brand of that, but each LHN would be expected to deliver that training. Yeah. So staff across sort of non-Aboriginal staff would all do that training.
And who, if anybody, checks that that training is actually undertaken?
So the LHNs have to record compliance against mandatory training, and that's an important KPI, particularly for accreditation. So that is collected routinely, and individual departments receive information about their department's compliance in completing mandatory training, and some of that does flow through to, we can request some of that. For example, if we want to look at child safe environments, what is the level of compliance across the state? We can request that information from the LHN. So, yeah, that is part of their service level agreements, I believe.
Thank you. I imagine that, again, the question about the number of Aboriginal staff in the workforce would be something that the local LHNs are going to have to provide us with
Across their
information
entire LHN,
Yeah.
do you mean?
Yes.
Or more specifically in child protection?
about child protection. We're looking at.
So in the child protection services themselves, as far as I'm aware, the only Aboriginal staff are in Narlan Child Protection Service, where they have 2 Aboriginal Wellbeing officers. So the service at Narlan is the newest child protection service, and that came out of the Narlan Royal Commission. So yeah, they have been deliberate in creating those positions in their unit. I don't believe that Sarlan or Women's and Children's, so the South or Women's and Children's Health Network, have any Aboriginal staff in their services.
Oh.
That's a question we can confirm, but that's my understanding.
And I'll also ask you to confirm in that whether that's because they haven't attempted to, or whether that's because they haven't been able to find Aboriginal staff who would be appropriate for those positions.
Yeah, it's probably both things. I think, and certainly through the model of care development for those services, we have recommended an Aboriginal workforce for these services, but that's not without its challenges. And Aboriginal people can apply, obviously, for non-Aboriginal specific roles in social work or psychology or medicine. That's the complement, or admin in those teams. Of course, in terms of dedicated positions, I'm only aware of the 2 in Narlan, but I think there are also is the challenge for Aboriginal people wanting to work in a service associated with removing with the removal of children. So not that the Child Protection Service themselves makes that call, but they work with children who have been removed and are in care, out-of-home care, through their out-of-home care clinics, and they work with children who have been harmed through assault and neglect. And for some Aboriginal people, that may be quite a challenging space to work in for them personally. And so I think that also has created issues. I know that the teams have certainly attempted to work in Aboriginal health services, based services in the community for their child protection, and Narlan does that. And I think Women's and Children's, but it has taken quite a while to work on those arrangements, to have for that to be culturally safe, I suppose, for those Aboriginal staff in those Aboriginal services to have a child protection service based there with them. And I think the same challenges probably apply in attracting a workforce. So that's something that needs to be thought of really carefully. And I think, we shouldn't have isolated positions. We should have multiple positions where there's support for those Aboriginal staff. Does that make?
Yeah.
Have I explained that?
One of the things we've heard.
Like I haven't explained that properly.
Well, I'm looking at an organisation like DCP who have a recruitment campaign for an Aboriginal workforce in that organisation, and obviously Health does an Aboriginal recruitment program around improving and increasing Aboriginal employment levels. So I'm trying to understand then with an area where child protection is a sensitive area in which to work for anybody. But there are really good measures in place in a sector like health to actually attract Aboriginal people into those roles.
Yeah.
So I am struggling to understand about why they haven't been deployed,
Yeah.
and because I actually think it's actually a resource issue that there hasn't been a decision to create
Oh, absolutely.
Aboriginal identified positions to actually attract
Yes.
Aboriginal people
Yes.
into that particular field.
Yeah. So that's why I said I think it's both. I agree with that. I think there hasn't been a workforce plan around let's recruit people, and that is one of the recommendations for the service model. But based on feedback we've received and conversations that we've had, that's the information that I've been told. So that's what I'm sharing back to say that it's, that might be one of the barriers to that as well. But I don't think they're insurmountable.
Got to develop strategies to mitigate those barriers.
Yes, yeah, because obviously, yes, other agencies do it quite successfully.
Yes.
One of the other issues that we've heard quite consistently with inquiry is the difficulty that Aboriginal people might have in getting a working with children check, because of one of the things we're looking at here is the statistics of the number of Aboriginal people who've come into contact with the department themselves. And so that may well then prevent them obtaining a working with children check, then their capacity to get into a hospital and work with families is blocked. Do you see a way around that?
And working with children check is not, not something I'm well across. I mean, I understand the practice. I guess that there are ways to work around things. It would be identifying a means to do that. We would need to work at a whole of government level across that to identify how would we overcome some of those barriers for people to enable them to access a working with children check. Yeah, I don't know the answer really, but I assume that yes, there would be ways of doing that. Would just require the brain trust to come together and the will to do it. Yeah,
Yes.
absolutely.
Yep. You mentioned earlier the assessments that are made. One of a quite clear problem that's been identified is the parenting assessments and the psychological assessments that are undertaken when a family comes into the sphere of the department, child protection, and those assessments are not done by anybody who's had any Aboriginal competency training, and so they're done through a white lens of what's appropriate parenting, what's appropriate bonding with children, what's appropriate in terms of attachment. In terms of the social workers and the psychologists within the system, the health system, is there any specifically Aboriginal family training done and competency done to address what looks like very strong Western bias in those psychiatric and psychological assessments that are then used in the youth court to remove people's children from them?
This is something that we've asked KWY to look at for the child protection services, is to look at the tools that are used and, what other culturally appropriate tools might be used instead of what we're currently using in those services. I think the staff will have done Aboriginal cultural competency training at some level, and probably in those services at a more detailed level than some other staff. But yes, it is acknowledged that, there probably are many tools that aren't really appropriate from an Aboriginal family point of view, and how family rearing practices differ from Western approaches. So that's something we've asked to look at. Wherever possible, I think tools are used. Across health, I know that the ASQ track is used to assess child development. So that would be in some child health and development teams and in child and family health service. So the ASQ track, assuming you're familiar with that, has been developed, or it's been around for several years now, and it goes across many domains up to about age 5, I think. So that's a child-related tool. And I know that DASA, so Drug and Alcohol Services SA, has been doing research around what tools they use. Now, that's not a child protection service, but they obviously work with people who have drug and alcohol issues. So they are currently looking at Aboriginal appropriate tools for their service. So I think it's something that we're increasingly aware of and needing to look to improving. Yeah, where they exist, I think they would be used. It's now how do we find and develop more tools that are appropriate.
Thank you. Again, another overwhelming theme that we're hearing in the evidence that's been provided to the inquiry is the power imbalance that is perceived or is perhaps real between the Department of Child Protection and all other external agencies, in that they have information about families that is garnered and not necessarily shared with other agencies. And one of the comments made was that as an Aboriginal person, you're the mouse and the department's the hawk, watching all the time, and then brings in all the other eyes to watch and surveil you, and then see that as health doing that in the hospital setting, and all the other agencies that people might connect with. They feel that they're agencies for the department that is just waiting and watching. What would you say to that comment?
Well, I think DCP does direct at some level and have some legislative power to do that, to direct other agencies to provide information, obviously working within information sharing guidelines, but the section 152 requests that come to health, for example, where we are required to provide them with information about children and families. We've tried to improve that process. That's probably more from a workload and efficiency point of view, from a health end, and work with DCP about how we can do that in a more streamlined way. But yes, we do provide that information to them. And I think in line with the comments made earlier, that there's probably scope to make sure that, or improve the way that we provide information, perhaps with more of a strengths focus rather than a deficit focus, which is what DCP would, well, that would be the information that they would focus on. But yes,
Is that your understanding, that the information they're requesting from you, well, not from you as an individual, but from health and health services, is to gain information that is strength-based? Is that your understanding when they supply a section 152?
Well, they're usually after information about what has been the interaction with the health system. So it's about attendance at appointments and things like that. I personally haven't completed one, so I haven't, pulled information together. I've certainly seen them, and it's information about, attendance at various appointments or failure to attend at various appointments, etc. And we've tried, as I said, that the LHNs have tried to streamline that as much as possible because it's quite time consuming to pull information together from case notes. And it can be quite difficult too because people might be called upon to do that who haven't actually themselves worked with that family, that child or family because of the time that's passed or whatever. So it's quite a time consuming piece of work that we are involved in. And I say it's usually just meant to be a collation of information that we provide back to the department. Yeah.
And the department define what information you give. They're not asking you to provide strengths-based information?
No, it's really more whether there is a particular pro forma that is used. I think it's really more general about what, and they identify which services within the LHN they want to know if there's been engagement with. It's usually at that level, like what's the engagement been with these particular areas, tick these boxes, and then it's sent to those areas to report in on that information.
So so the system doesn't know what its information's being used for?
It's usually for a court process, I understand. And that's, sometimes the timeframes are quite tight to provide that information.
Thanks.
Do you have any questions?
I do have a question. You might not be across it, but I'm going to ask the question. So family group conference is something that the department can request in relation to a child and their family, and in which decision making can happen. We have heard from some of our, some of the people that have been providing evidence about the importance of health being in a position to actually request a family group conference for, an unborn child concern or a high risk infant. It is something that has been raised, at various, times. I'm wanting to know from yourselves whether you're aware of those coming from, whether it be from the Aboriginal community or from others across government, about the role in which health can have in requesting a family group conference, particularly if there's engagement that you have with a mother through an unborn child concern. Are you aware? And
I'm certainly aware of family group conferencing as a concept. I'm not aware. I wasn't aware that health could request that.
Well, I don't think you are, but I think there's been lots of calls for opening up to other agencies to actually make referrals to family group conferencing as an early intervention strategy.
Yep. Okay. I can't answer on behalf of the staff in the service delivery about whether they're aware of that and whether they have ever done that or been involved in that. But I'm aware of what the family group conferencing is, and that seems like a positive early intervention strategy that would be great to make use of.
Thank you.
Yeah, that's my question.
Thank you. We'll finish that there. Thank you for the recording. Thank you very much for your information.